A very warm welcome to everyone. Thank you again for joining this educational webinar. I'm very lucky to have so many people join from very different parts of the world, so I appreciate that and thank you for that. My name is Vik Dudhia. I'm the Senior International Corporate Trainer here at Neolight, and I'll be your host today. The webinar is brought to you by the Neolight Education team on our CARES program, which supports, of course, the effective use of our products through educational support and shared best practice. CARES stands for Continuing Advancements and Resources in Education Support. And lots of information can be found on our website, on our products, and also therapy areas that we cover. And please check back on the website often. It's theneolight.com, theneolight.com. And we're always updating that information, so we'll make sure that you check that. Today's webinar will focus on ROP, Retinopathy of Prematurity, screening, a physician's perspective. We have a very esteemed guest who's going to share his insights with you today. But before we get started, just a little bit of housekeeping. We're going to keep everyone on mute. We're going to have the cameras turned off, and we'll and to avoid any kind of unnecessary distractions. One thing I will say is that if you have any questions during the conversation, then please submit them on the chat. And we'll address those questions at the end. Thank you so much for that. So without further ado, please allow me the pleasure of welcoming our esteemed guest, Professor Domenico Lepore. He's the Associate Professor of Ophthalmology at the Catholic University of the Sacred Arts at Gemelli in Rome, in Italy. He's also the president of the Italian ROP study group, ROPITA, and also the Executive Secretary of the World ROP Council. So it's my very great pleasure to welcome you, Professor Lepore. Thank you so much for taking the time to join us today.
Thank you to have the opportunity to share with you my experience and the work that we are trying to do on this very, very fantastic field that is taking care of these small kids that need our expertise to have a good and fantastic life.
Absolutely. Thank you, Professor Lepore. So let's kind of set the scene for all our attendees on the webinar. Could you give them a little bit of insight about where you work, the type of patient groups that you're looking after, and kind of what your workings look like?
Yeah, I think I will try to start the story on how I get interested in this field, and it was many years ago when I had the chance to be sent by Professor Bagolini, who at the time was the chair of my institution, to Philadelphia, where I was trained by Grant Quinn, which is the father of the first and second international classification of ROP. And I had the opportunity to be trained on laser on these kids by Bill Tasman, that was at the time the chief of retina service at the Jefferson University. And coming back to Italy in '92, I was in charge of organizing the screening of that at the moment was the largest Italian NICU and with more than 20 intensive care beds and a lot of people, there are a lot of babies referring from other hospital from the southern and central Italy. At the time, it was we don't have the icon, so and eventually on any kind of digital imaging, and we were using just indirect ophthalmoscope. Then the wide field camera became available 10 years after, and we started to collect images and starting also to use fluorescein angiograms, which is probably the work that I've done and that is most recognized in worldwide. Fluorescein angiogram was used as a support of diagnostic, was not essential in the screening activities, but was only the way we get confident on the indication of treating these kids. At the time, the treatment was laser, and also the laser was very complicated, and the use of wide field digital imaging helped us to have a more complete and performance and well done laser for the ablation of the vascular peripheral retina. Now we are in the largest NICU in Europe. We have 40 intensive care beds and quite a busy department. We organize a very intensive cooperation with neonatologists in the intensive care unit, but we also have been able to structure the follow-up with pediatric neurologists and also the other specialists that take care of the premature, any kind of people that try to rehabilitate the kids, or people that is interested in visual assessment and motor assessment and cognitive assessment. And this is, I think it's quite a unique experience, because we can follow these kids starting from the discharge from the NICU until they become the school age. And it is very important, because you can really understand how good was your work in the NICU, just looking these kids growing up and seeing how many problems that the mistake you made in the NICU can cause in the future life of these kids. Only following them during the life. And at the moment, we are 3 people that are in charge of the screening. I personally coordinate the 3, and I really act as a supervisor. We follow strictly the UK guidelines that recently has been published in the Human Development Journal. So we also have a sort of referral, a way to confront the decision you take with other people that are outside our institution. And in this case, the fact that I'm president of the Italian group helps us to create this kind of network, to be confident. We have to confront each other on the decision we take every day, and this makes the things much more easy. And we use at the moment we have been able to use a lot of digital imaging systems. At the moment, we use Icon, happily, I should say, and we use the fluorescent angiogram system that Icon provides us. And the fact that Neolight is trying to support us in terms of creating a network to share the images, to create a database of these images, it is very important, critical. The machine is used also in the follow-up, but only when we do the examination under sedation, so in the operatory room, while in the regular follow-up with the baby awake, we are now shifting toward another system, which is the Optos, that is more easy to be performed because it's no contact, and is more useful for the bigger kids. I have also to tell you that in 2 years ago, I've been elected executive secretary of the World ROP Council. We are trying to create the same experience some countries are already in place. That is the network and the sharing experience of treating and the treating criteria that we use worldwide. And we will organize a meeting in December in Rome, worldwide ROP, in conjunction with the meeting that is well known now among the retina specialists worldwide. It is Floretina. The meeting will be held in Florence from December 4th to December 6th, and hope that you will have the opportunity to participate. And in case you're not able to come, we're also providing through people and sponsors that will help us to diffuse this meeting, also with the online webinar and with online participation to the meeting.
Thank you, Professor Lepore. And And you and I have spoken about World ROP, which is happening, as you said, in December, so later this year. But we'll be able to share information about that and our possible participation in that meeting. But we will share that information with the people who have attended this webinar. Just going back to a couple of things that you said before, I didn't realize that one unit was the largest in Europe, and that's incredible. And I think you and I have spent some time together working together, so I always appreciate the time that you give me when I come to visit you, and I always learn so much when I spend that time. What is it? What does a typical day look like for you? Because our audience who are attending the webinar today have come from very mixed backgrounds, professional operation. Some of you are potentially maybe still using indirect. Some who maybe have a device, and we have everyone who maybe we have other individuals maybe who are thinking about possibly launching into using a digital camera such as the iPhone. So could you maybe just share your experiences of kind of what it was like before versus how it is now using the icon, and what difference the difference it's made to you currently?
Yeah. First of all, I should tell you the story about the new classification. I've been involved in the committee since the 2018, and I think that still we have to consider the indirect ophthalmoscope the gold standard, because this is not because of the quality, of course, but this is because of the availability. Unfortunately, there are a lot of places that cannot afford a wide field camera, and so we had to provide a system to classify the kids and to have a common language based on the indirect ophthalmoscope images. But this is becoming more and more complicated, because it is impossible to share the information with other experts, even in the same institution. Sometimes it's difficult because you cannot go back and forth and to examine the kids if you have doubts. So I think that what the icon make life much more easy for us, because I can screen, staying in my office, looking at the images, and having the camera used by nurses. We have right now, it's the first place in Italy that has nurses that are able to use the icon. But I mean, unfortunately, we have much more performance, much more better wide field cameras than icon is. I think one of the best that the market offers. So the idea of having the wide field camera digital make life much more easy. It is possible to teach, which is another important aspect, where we don't have to bring with us the resident to screen the baby. We can show the baby, we can show the images to the resident, and we can have discussion with them, and trying to make them able to take the clinical decision based on the digital imaging. And so I think in the future, hopefully, also because I mean the cost probably will go low and low. We will be able to screen only with digital imaging, and in terms of quality, in terms of didactic opportunities, for sure, icon change our life, and is still improving. I have to spend one word about fluorescein angiograms, because it is not included in ROP just because it's not so spread worldwide. In some countries, there are still some difficulties in convincing the parents to have the examination done because of the use of the dye. We believe that the procedure is safe. We just based on our 30 years experience, but just to improve and to make the parents more skeptical about that, we now shifting toward the use of oral fluorescein. Oral now scares much less the parents that feel that drinking a milk with some orange dye inside is safer than injecting them in the vein, and so this is probably the way we can be able to spread the use of fluorescein worldwide. And fluorescein is in some case the best way to visualize the vessels in the periphery, even in a very good image that we can be able to get with the icon, and also to probably be able to diagnose the tendency toward the plastices earlier, and thus improving the results of our treatment. I have to tell you that we in the committee of the international classification is still there. We talk each other every monthly base, and the idea is to launch a new study to pilot study, but the idea is to launch studies to maybe treat earlier than it was that is done now with the ROP criteria, just based on the opportunity to understand which would be the baby that progress toward plastices and which will develop that regress. And fluorescein angiogram, of course, will play an important role in this study. And another study is conducted with integration of the icon images and laser Doppler measurements of the speed of the flow, which is probably the key factor that will allow us to understand why some kids progress toward plus and why others actually regress and the ROP disappear.
Oh, thank you. I know that just want to touch on a couple of the points that you made earlier on, Professor Lepore. In terms of having universal ROP screening, we focused on that just a couple of weeks ago in our webinar on that, and we had a great attendance of a lot of nurses from around the world who are either screening already or about to start their journey into screening. So I think, I feel that from the conversations I've had with the Eastern Black Slide, it's certainly moving in many countries. And it's nice to hear that you're one of the sites in order to be that's pioneering that. You mentioned also about training others. How easy has it been to just kind of pass on those skills and to train others? Not necessarily with the icon, but how have you done that in terms of training others? Because like I said, we have a mixed group of people attending this webinar. So they have some people who are very early on in their journey. So it'd be nice to hear how you came up that training.
Thank you for this question, because Vik, I have to tell you that and confess this is very difficult to attract young ophthalmologists to work in the field of pediatric ophthalmology in general, and particularly in the field of pediatric retina. This is because I have to confess it's very difficult, and young people is more attracted toward the cataract surgery or vitreoretinal surgery that are probably in terms of revenue much more attractive than it is the ROP. What we try to do as a executive secretary of the World Council, this is one of the particular objective of my task in the World Council, is to fascinate the young ophthalmologists, because this is really a unique occasion to see the vessels grow and the retina to develop. And many of the information we use now on our, let's say, oncology or tissue engineering comes from the information we got from the experimental model of ROP. I had the opportunity to work with tissue engineering, and in particular the group which is very active in Naples, that is connected with Boston, Massachusetts Institute of Technology in Boston, and they learned from us. They learned from the way we saw the vessels growing in the retina, and reproducing these models has been the key to be able to let the vessels grow inside the artificial tissues. And another possible application of what we are learning from ROP is in oncology, and part of the experience done with the VEGF really comes from the oxygen-induced retinopathy model. And another important and attractive is that attractive of the ROP is that you can understand how important is to the concept that the gradient of the VEGF is related to the local and space regulation. We need to block just not the entire retina, but just the retina on the front of the vessel's growth, and plus the time factor. Time factor is critical when you use growth factor, because VEGF can be useful in the first phase of vasculogenesis, so in the phase 1 of the retinopathy of prematurity pathogenesis, and this has to be eliminated in the phase 2. So it is important that the time when you treat this kind of vascular pathology is fundamental. What we are now seeing, thanks to the use of the wide field camera, is that if you inject the kid very late, this will cause, of course, the stop of the vascular pathology, but not the fibrosis. And so it is becoming more and more popular to see fibrosis on the surface of the retina without any vessels, and the growth of the vessels stopped stopped in the mid periphery, and not be able to progress toward the ora serrata. And this is just because the injection maybe is done too late, or too early in case of in some case, and or too much if you inject 2 or 3 times, because since the procedure is very easy to be performed, sometimes people is scared about the reactivation of the pathology, and they inject again. So while if you look at the study that we have done with Lucentis and with IDEA, it is clear that the reactivation, the significant reactivation after the acute phase is very, very rare. Even in Lucentis, which is the molecule that performs less than the other one, the reactivation of the 20 to 30% reactivation is only seen in the first 60 weeks of postconceptional age. And after that, it is very rare. It's so rare that we haven't seen any case in the Rainbow study, and only 2 cases in the Firefly. So, and this is possible only because we are able to use this kind of wide field camera. We are able to use the fluorescein angiograms that allow us to understand precisely the exact time when the pathology reactivates. And so, given all this information, I think that who approach this disease with a scientific spirit, I think is one of the most fascinating pathology in the entire medicine. So that's why I always say to my students, don't be scared to face this kind, but try to understand what's going on, and try to apply the information that got from the first year of the School of Medicine directly into the eye of these kids. And I think this is the best advertisement I can make to make the people be attracted by being an ROP expert.
Yes, you always share so much fascinating information with me every time I speak to you. And I have so many questions, and I'm probably won't have time for all of them. But do you think, I just want to pick a couple of things. Thank you again for your insights. Um, as I've been working around and supporting in different countries, and you and I have spoken about this as well before, that, it is very difficult to recruit young pediatric ophthalmologists into this, just because maybe they're attracted to other areas, which is understandable. And in some countries, universities are filling that gap. But what would you say to someone who's kind of just considering it, um, considering everything that you just said? I think if I was in at that point of making that decision, having listened to what you just said, I think for me it would be very simple to go into that field without a doubt. But what would you say to young pediatric ophthalmologists who are kind of maybe just considering ROP? Or what is it about that should attract them? And where I think specifically the question is, where do you see the treatment of ROP in the next 5 to 10 years? What's your vision?
Oh, first of all, I forgot to tell you, the best way to attract young ophthalmologists to take care of these kids is to see the kids growing. And I'm becoming old, and I had the opportunity to have my until now 3 degrees, 1 in law and 2 in medicine, by my former patients in the NICO, and this is the best way to see how good is your work. I mean, how worth is our work with these kids. What will be the future of the ROP? We have, I think, 2 mainly differences. First of all, improving our ability to detect and to select the kids that are progressing towards the severe ROP and need treatment. And this could be done with these new studies. We have a new language, which is the ROP. I think this is well prepared to be used with all new kind of instruments we will have, and so the first would be to improve the treatment criteria. At the moment, we use the ROP, which is has been useful over this time, but now is the time to have new criteria. And the study that in US are starting probably will give us in 1 or 2 years a right answer. But even outside the big multi-center study that we need to reach some statistics significant, everybody can do his contribution in a single center, very well designed study to modify and to propose new criteria to modify the treatment. And this is the first. So in terms of how to treat what kids need to be treated. And the second is to follow how we have to follow these kids, because now with the new drugs, we change the type of the pathology we are facing. When I started, it was something like done and yes or no. I treat the kid, and if the treatment is okay, then fantastic. It will regress, and we will have a good quality of vision. And if the treatment was failing, then we had nothing to do. And even the vitrectomy, I have to tell you that I consider vitrectomy a failure in the screen. So if you have to do vitrectomy for this kids, seems that something is wrong in what you have done before. So now with the anti-VEGF, we treat the kids. We have to face the risk of, as I have to tell you, the risk is in some time overestimated, the risk of reactivation. But then you have to face also the fact that in many cases, the retina stay avascular in the periphery for the entire life. So what we have to do with these kids? And so the pathology is changing from a acute to a chronic pathology. And this is another change that we have to face, because it is important to organize your service not only with a screening inside the NICU, but also in a good follow-up program. And this is another important challenge. This is another important challenge where technology and a company like Neolight can help us to improve, because we need the instruments that are designed not only for the intensive care unit, but also for the follow-up phase in kids that are 2 or 3 years old, that are very difficult to be examined in the clinic. And so this is what the future of ROP. And maybe new drugs with a different ability to interfere with the vasculogenesis in a different phase of the vasculogenesis, not only with anti-VEGF, but also with other growing factors that intervene in the stabilization phase of vessels. And this is another important issue. And the most important, last but not least, the artificial intelligence. Artificial intelligence is changing the way we treat these kids, because we will be more confident when a machine that is able to analyze the images in a very safe and fast way can support us in the clinical decision. When we started to use artificial intelligence with Darius Mosfighi in Stanford, by joke, we make the discount. And in our, Darius and I are almost the same age. And we considered that we were screening about 42,000 kids in our entire life, and which is a good experience in terms of humans. But you have to know that our new temporal neural network is able to screen 42,000 kids in only seconds, and is not tired, is not angry, is not influenced by any kind that happens in around you. And so this is the support that we want to try to spread all over the world, and to make the people more confident in taking their clinical decision. And this is another important and fascinating challenge that we are undertaking in this moment.
I just wanted to pick another topic that you mentioned earlier on, just if you wouldn't mind sharing a little bit more information. You spoke about the timing of anti-VEGF and how crucial that is. Could you give us a little bit more information about that, your thoughts, and how do you think that's going to change? And when do you think that's going to change? When will that become kind of the gold standard?
Yeah. To make the clear point, we still use ETROP criteria. So plasticity is essentially the key factor that we have to see to decide the treatment. But the plasticity is a very individual call. We are now 3. I am a supervisor, so I have to interfere with the 3 ophthalmologists that screens directly. Sometimes it's difficult to reach an agreement among us to call these plasticities. And in this case, ROP, the artificial intelligence it would be very important. But what is more important is that going back to pathology, to physiopathology, we have to understand why the vessels become tortuous and why the vessels become congested. This is because in the far periphery and in the center. This is because in the far periphery and in the junction area between vascular and the vascular retina, shunts creates from arterial to vein. This increases the speed of the flow, and this increased speed of the flow causes the tortuosity and congestion. So And this is very clear when you see the fluorescein angiograms, because you have the opportunity to see the vessels going from the arterial to the vein part of the circulation, and probably if we are able to catch the exact moment where the shunts become clinically significant and start to affect the entire circulation of the retina, this is the moment where you have to act. You don't have to wait the clear, massive tortuosity and congestion. So since we have now less invasive, less destructive system to treat these kids, probably injecting at the exact moment when the shunts become so important that affect the speed of the circulation, then that would be the moment. And I offer you an idea to realize a new study. We need more study on this subject. We have now instruments. I told you that can be evaluated together. Laser Doppler can help us in understanding the modification on the flow speed, together conjuncted with fluorescein angiogram. And one more word is about angio-CT. In this case, angio-CT is not useful because angio-CT is a photo of the vessels. While with the fluorescein angiograms, we made a movie, and the movie is much more important to understand the circulation compared to the single shot that you can have with the angio-CT. So still, the role of fluorescein angiograms is important in the management of ROP.
Thank you, Professor Lepore. And I just want to invite our attendees, if you're having specific questions about that topic that Professor Lepore has just addressed, feel free to put them in the chat section, or if alternatively you want to be connected with Professor Lepore, please let us know, and I'm sure that you'd be happy to connect with you on that particular topic. So thank you so much for that. So what change director a little bit. What's the one piece of advice that you would give somebody that you wish you had been given up when you were early on in your career in our school?
Yeah, many years ago. I think about how can you modify and improve the quality of life, not only of the kid but the entire family. And I've seen in my entire career, I've seen family destroyed by the experience of having a premature baby, and I think that supporting with our scientific knowledge, trying to support the family in this path, which is a lifelong path. It is the most important thing that I think that supports my way of dealing with this pathology. So I think that keep in mind that these small things that you are treating, you are discussing about is a new life, and the life would be what you are doing will affect the life for so many years, and the entire family around these kids can be also affected. So think about the aspect of the human being that you are treating. This is not only patients are really a new life that needs your expertise to be fantastic, to be lead.
No, thank you so much. Did you want to speak at all about the classification? I know that that was something that you mentioned earlier on. Classification is at times can be subjective, and I know that you mentioned the importance of technologies such as AI in helping that classification. Did you want to talk some more about that? Just a little bit.
Yes, just to clarify, but this is critical because it's the language that help us to exchange our experience even in absence of images, and we we didn't change too much in the classification in terms of stages, in terms of classes, definition of classes. We made some subtle changes. In terms of plus, the most remarkable, in my opinion, is the use of the scale of plasticity. So don't think about plasticity as a yes or no. Plasticity is an evolution. So it is not a picture, it's a move that goes from normality toward clear pathology. And you have to go back and see the kids, the images of the kids if you have a wide field camera, but even think in your mind, draw your what you have seen with your indirect ophthalmoscope to understand how these things are changing, how the tortuosity is progressing or regressing. And in this case, drawing is important if you don't have if you don't have wide field. I mean, and even going back and seeing the kids every 2 or 3 days is a huge amount of work, but this can help you to understand how the baby is progressing. So first of all, don't think about plasticity as a yes or no. Plasticity is a progression, and the diagnostic must be granular. So you have to understand the small little changes that makes the kids progressing towards or regressing. This is the best. I think this is the most important new things that we offer with the iCrop 3. The second one is about zoning. Zone 2 is where everything happens, but zone 2 is not the same. We have anterior zone 2, we have posterior zone 2, and in my experience, we are now reviewing all the cases that we treated since 1998, and posterior zone 2 defined as an extension of zone 1 with two diameter of the disc diameters from the border from zone 1 and zone 2. The posterior zone 2 is almost the same as zone 1. And almost, I should say 90% of the cases that we classified as zone 2 were in the reality has to be classified as posterior zone 2. So this is another important thing. And plus, forget about zone 3. In many cases, even from people that come, kids that come abroad, as classified as stage 3, zone 3, which is something that, clinically is really almost impossible to be seen. So it is a clear mistake. And observing and looking at the periphery is very difficult. I understand that it's very difficult. Sometimes if you don't have the icon, then you have to use your indirect, you have to indent and to understand, because probably what you classify as zone 3 is an anterior zone 2. And in this case, the use of wide field camera, and in particular, I have to remark that the quality of the images in the periphery is critical. Don't be fascinated by the word 130, 140, 180, because the quality of the images is very important. So it's better to have a small field, but very high quality, same quality there in the center compared to the periphery, instead of having a very, very large visual field with a very poor quality in the periphery. And the third thing that I have to highlight in the new iCrop classification is the way we can classify the reactivation or regression of the pathology. Is the same that we use for the acute phase, has to be remarked with R in terms of regress or reactivation, if there is any reactivation, and the criteria to consider reactivation, the treatment in the reactivation phase is the same that we use for the acute phase. So don't treat everything when you see something reactivating, because you can see the stage 2, reactivated stage 2 that are almost clinically insignificant, and they go away by the time. So don't treat any kind of reactivation, because we see a lot of mistakes done because of too much retreatment. And this is another instruments that the ROP offer use in terms of clarifying the situation and make the confrontation possible.
Thank you, Professor Lepore. We're going to bring this webinar to a close. So before I do that, I want to thank my colleagues at Neolight for their support. I'd also like to thank all our attendees. And last but not least, my gratitude to you, Professor Lepore, for taking your time out, sharing your expertise and your insight. It's always a pleasure and a learning experience whenever we spend time together. So thank you so much. I know that you have a busy day today, so I appreciate your time. Thank you so much.
Thank you, and have a good day. It was a pleasure to be here, and we'll be more than happy to be in contact with you if you need any help or any kind of information about what we are doing with the International Committee and with our World ROP Council. Please be free to contact me directly or via the Vik information. Okay.
Thank you, Professor Lepore. And we will make this webinar available on our website, so you will be able to view it again and listen to the conversation. If you're interested in connecting with Professor Lepore, you can contact me at Neolight. My contact details will be at the end of the webinar, and I can address those. If you have any questions as well that you think of after we finish the webinar, again, please tell me. I'll be happy to solve it on your behalf. So thank you again, Professor Lepore, and thank you to all our attendees for great talk. Thank you so much.